Yes, sir, you can go ahead.
Good morning, everyone. On this beautiful Sunday morning, we are blessed to have one of the best speakers in the country who are going to give us insightful learnings on hypertension management and telmisartan usage in hypertension. So today we have for this session, our moderator is Dr. V. Chandaraya. Dr. V. Chandaraya is a senior consulting physician at Sagar Hospital. He was ex-professor and HOD of medicine at KIMS Hospital, Bangalore. He was secretary MERT. Apart from this, Dr. Chandaraya has also held positions like co-organizing secretary EPICON 2018 and organizing secretary CAPICON 2006. Dr. Chandaraya has been awarded as the Rotary Bangalore South Dr. H.V. Rajashekara Setti Community Service Excellence Award. And apart from this, he has also received Physician Award for the year 2015 and 16. So thank you, sir. Thank you for giving this opportunity to us and to giving us the opportunity to take this session. And with this, sir, I would like to hand over this session to you to introduce our speaker for the day, that is Dr. Narayana Murthy. So over to Dr. Chandaraya. Sir, kindly unmute yourself, Dr. Chandaraya. Sir, it's mute, sir.
Okay, I'll just.
Yeah.
Good morning, everybody. At the outset, I thank Zydus for arranging this webinar meet, especially on hypertension management with respect to the telmisartan. Now, for which we have my good friend Dr. Narayan Murthy, who is well-known cardiologist of Bangalore, who is an intervention cardiologist. He has done both MBBS, MD cardiology from Russia, and he has awarded FACC from US. Presently, is working as a senior consultant cardiologist intervention at Sagar Hospital, Bangalore, and is also the worked in various capacities at different centers, both internationally and nationally. He was a consultant intervention cardiologist working at International Airable Kampala. Then also he has worked in Abu Dhabi in GMC Hospital. Then he has worked in various centers in Bangalore, including Mahavir Jain, then Trinity, and he was also associated with one of the prestigious medical college, that is PS Kuppam. Now he has various achievements to his credit. He has chaired session at the annual conference at Ankang. Then also he has attended ACC and TCT conference in US, and he has also attended the conference at Jerusalem, Israel in 2013. And he has various publications to his credit on genetic forecasting and prevention and maintenance of essential hypertension, and also management of pacemaker syndrome in patients with fixed CNS syndrome. He has various international publications to his credit. Next. I think with that introduction, now I welcome Dr. Nayan Murthy to start his session to talk on hypertension. Start.
Thank you, sir. Thank you very much for the kind words and introduction. Shashi, I would like to just go on to my slides. Just give me a minute. I'll just share my slides.
Sure, sir, sure. Sir, your video is frozen, sir.
Your videos.
Yeah.
1 second. It's loading. One moment. I'm just finding a little. Give me a minute. I'll just.
Yes, sir. Please.
Just.
Sir, is there any issue, sir?
Yeah, that this one, it's not getting shared. I'm
Sir,
trying
can
it.
you please?
सर नीचे
Can
की
you
तरफ
just
शेयर लिखा
one
होगा
second, yeah. Share it's yeah.
and screen select screen. Yes, sir, it came. Now you can open presentation, sir.
Yeah, I'm trying to, yeah. You see now?
Yeah, sir, just go back to the first slide. Yeah.
Yeah.
Okay, sir. Now you can go ahead, sir.
Shall we start? Yeah. Sorry for the little inconvenience there. Yeah. Thank you, sir, Dr. Chandraya, sir, for those introductory words. Thank you very much. Today's very, very interesting topic that we are going to talk about beta blockers based combination after telmisartan. It's been ages now that all cardiologists and the physicians have been using beta blockers for ischemic heart disease, congestive heart failure management. We all know that we have been using it, but only thing that we were a little bit hesitant to use this combination in many of our own patients for a simple reason that we usually had this idea that the beta blockers were not real indications. There were many contraindications, like for example, COPDs, bronchial asthma, many other such things. But trust me, we have been using these beta blockers for quite some time now, and we have found that beta blockers never ever caused any major um, problems, even in the elderly patients, except for a few of them where they used to have sick sinus syndrome or AV blocks. Other than that, many of these patients did pretty well with the combination therapies along with ARBs. So I'll not go into the details of that, but to start off with today's presentation, let's look at the preamble. Hypertension is commonly associated with ischemic heart disease and the heart failure. The beta blockers reduce the overload and the oxygen consumption of the heart, which is beneficial in the ischemic heart disease and congestive heart failure. Beta blockers are highly effective not only to control the blood pressure, but also reduce the symptoms of cardiovascular events in ischemic heart disease and congestive heart failure. Here, we review the evidence of beta blockers in the hypertension with the ischemic heart disease and congestive heart failure, in addition to telmisartan or an ARB. If you look at the metoprolol in hypertension, that is the Murphy study, there were 3,234 high-risk hypertensive patients with the diastolic pressures between 100 to 130 millimeters of mercury were randomized to the metoprolol or diuretics with hydrochlorothiazide 50 milligrams for primary prevention of CHD. So the baseline cardiovascular risks were as follows. The total cholesterol was 244 milligrams, the BMI of 27, and the blood pressure of 166 by 107 millimeters of mercury. The mean follow-up was for 5 years, and the endpoints that it looked into was the total mortality, the cardiovascular mortality, and the non-cardiovascular mortality. So coming to the Murphy study mortality as against the diuretics, which was published in, we can see that the clear-cut benefit of the metoprolol when compared to the diuretic. So there was a 48% reduction, 58% reduction in the CV mortality and non-CV mortality. The total mortality was 48% and the CV mortality was 58% respectively, and 28%, 29% in the non-CV mortality. So in conclusion, the metoprolol was more effective than the diuretics for the cardiovascular disease prevention in hypertensive patients. So metoprolol, let's look into the metoprolol in stable angina. In a crossover study, there were 52 patients with a stable angina who were randomized to the metoprolol, succinate, and amlodipine for 4 weeks in sequence. At the end of each phase of active treatment, the patient's clinical progress was assessed and 24 hours ECG monitoring was performed. So the endpoints that were looked at were number of ischemic episodes on the 24-hour ECG monitor, and the total duration of the ischemic episodes in 1 minute, and the number of anginal attacks per week, and the percentage of the patients without ST depressions in the stress test. So this is the metoprolol in stable angina, number of ischemic episodes in 24-hour ECG, p-value less than 0.01 for metoprolol versus amlodipine. So the metoprolol, if you look at very carefully, when compared to amlodipine, significantly reduced the total ischemic burden by reducing the ischemic episodes and the anginal attacks. So coming to the MERIT-HF post myocardial infarction sub-analysis, in the MERIT-HF study, the congestive heart failure NYHA class 2 to 4 patients with a reduced ejection fraction of 40% were randomized to metoprolol or placebo. A sub-analysis was carried out in 1,926 patients who had recent myocardial infarction in the past, and 85% patients had myocardial infarction more than 1 year back, and 95% were on AC inhibitors or ARBs. So the endpoints that were looked at were the total mortality, the sudden cardiac death, and the all-cause death or the hospitalization for the worsening congestive heart failure, the cardiovascular death, and the non-fatal myocardial infarction. So this is the post-MI sub-analysis result of MERIT-HF. There was a 40%, significant 40% risk reduction which happened in the metoprolol group. So that sudden death, the risk reduction was 50%. Amazing. So the post-MI sub-analysis results, the all-cause mortality, the total mortality, everything has been clearly shown in this particular slide here. So to conclude, in post-myocardial infarction patients, with the symptomatic congestive heart failure on AC inhibitors or the ARBs, the metoprolol succinate exerts a profound reduction in the mortality and the morbidity. So the beta blockers with the RAS inhibitors in post-myocardial infarction patients. So let's look at the AIR study, which included 1,986 post-myocardial infarction patients who were randomized to ramipril or placebo, followed up for 15 months. In a sub-analysis, 443 patients were on beta blockers and compared to 1,543 patients not receiving beta blockers for survival analysis. So the beta blockers with the RAS post-myocardial infarction on beta blockers and non-beta blockers. Let's look at the curve which goes this way down there. There was a 34% reduction in the on the beta blocker when compared to the non-beta blocker. To conclude, in the post-MI patients on the RAS blockers, chronic beta blocker therapy reduced the mortality significantly by 34%. That was a significant number. So let's look at the metoprolol in post-myocardial infarction patients meta-analysis. The data from 5 clinical trials were pooled to evaluate the effect of the metoprolol on the mortality in post-myocardial infarction patients. A total of 5,474 patients, out of whom 4,353 were men, 1,121 were women, were randomized to metoprolol or matching placebo. The follow-up ranges from 3 months to 3 years, and 4,732 patients years of observation had been obtained. The endpoints that were looked at was the all-cause mortality and the sudden cardiac death. So what are the results? Let's look at the result. The metoprolol significantly reduced the all-cause mortality with the mortality rates of 97 and 78.3 per 1,000 patient years for placebo and metoprolol group with a significant P 0.036 respectively. There was a marked reduction in the sudden cardiac death, which was noted. So to conclude, the long-term metoprolol therapy in post-myocardial infarction patients reduced the total number of deaths and especially the sudden cardiac deaths. So it's very, very important to continue beta blocker therapy for a long term in post-myocardial infarction patients. That's what we have all been following up. So let's look at the resolved pilot study, the metoprolol in congestive heart failure patients. In this study, there were 426 symptomatic congestive heart failure patients taking ARBs and AC inhibitors were randomized to metoprolol or placebo for 24 weeks. 64% patients had history of myocardial infarction. The endpoints that were looked at were changes in the left ventricular end systolic volume and the left ventricular end diastolic volume, the changes in the ejection fraction, changes in the ANP, the BNP levels, and the all-cause mortality. So the result, so look at the changes in the left ventricular volume, which is seen in this particular slide. In congestive heart failure patients, metoprolol significantly reduced both the end systolic and the end diastolic volumes. So what happens to the left ventricular ejection fraction? Look at this. In the heart failure patients, metoprolol significantly increased the left ventricular ejection fraction. So this is the result pilot study, and this is what we had to look at. In congestive heart failure patients, metoprolol significantly increased the pro-NP and BNP levels while reducing the renin and the angiotensin II levels. So result pilot study mortality was lower in metoprolol group, 3.4% versus 8.1%. So to conclude, when added to the AC inhibitor or an ARB or both, the use of metoprolol improves the ventricular function, reduces the activation of the renin angiotensin systems, and results in a fewer deaths in congestive heart failure patients. So this is the AHA 2017 guideline recommending the beta blockers with ACE inhibitors or ARBs for stable ischemic heart disease patients. It also recommends not to use, let me clear it, not to use atenolol in ischemic heart disease patients. Very, very important point. So the ESC hypertension guideline 2013 also recommends ARBs plus the beta blockers in hypertensive plus ischemic heart disease or congestive heart failure. So this goes without saying that the beta blockers can be and have to be recommended in ischemic heart disease patients and in congestive heart failure patients in the long term. So the ASH, ISH guidelines also recommends the ARBs plus the beta blockers in the hypertension plus ischemic heart disease, congestive heart failure. So this is what is the evidence when the hypertension is associated with other conditions. This is what they recommend: the beta blockers plus the ARB or an ACE inhibitor. So what is the take-home message? Metoprolol significantly effective in reducing the cardiovascular events in hypertension and in ischemic heart disease, congestive heart failure patients. It reduces the anginal attacks and provides symptomatic benefits. The concomitant usage of ARBs and the beta blockers are recommended by international guidelines for hypertension plus ischemic heart disease patients. So the use of beta blockers, especially the metoprolol, are rational add-on to telmisartan or other ARBs for patients with the hypertension with the ischemic heart disease and congestive heart failure. Thank you very much.
Yeah, so Dr. Chandaraya, I would request you to take the queries which have been posted by the audience. It seems Dr. Chandaraya has some net issues, so I will take the queries one by one, sir.
Yeah, let me see if I can answer any of these queries.
Sure, sir, sure. So coming to the first query, sir, it is from Madurai. Dr. Kumarakam has asked which ARB is having the maximum data with respect to beneficial effects on target organ damage.
Yeah, very, very interesting question there. I think most of the studies which have been conducted worldwide goes on to say that it is the telmisartan and olmesartan both as effective, and I think usage of these two ARBs are very, very significant and effective.
Yes, thank you, sir. The next query comes from Hyderabad. Dr. Vijay wants to ask which is the better modality for monitoring blood pressure, ABPM or HBPM?
I think Dr. Chandraya would be in a position to answer that question, sir.
Hello, can you repeat that question? Am I audible?
Yes, sir. Yes, sir. You are audible, sir. So the question is, which is a better modality for monitoring blood pressure, ABPM or HBPM?
Now, it all depends on the people's convenience. It is the HBPM is ideally we can do easily, whereas ambulatory blood pressure will have their own issues. I think we only when we are finding difficult to monitor, adjust the dose of the drug for a short period, we may use the ABPM. Or if we have to diagnose white coat hypertension or those who are having the blood pressure when they visit the office at home, they say it is normal, then probably those settings we use ABPM.
So the next question is from Delhi, Gurgaon. Dr. Sanjay wants to ask, telmisartan is preferred in patients with type 2 diabetes mellitus due to PPAR gamma activity. which may have beneficial effects on insulin sensitivity. Sir, please share your views.
And Murthy, want to answer? You are muted, Naran Murthy.
Yes, sir. I would like to take that question. Yes, there is a lot of evidence to say that telmisartan has been very effective in diabetic patients, and the latest data which has come out in the recent past suggests that there is a beneficial effect in diabetic patients when they are on telmisartan as antihypertensive, and it goes beyond anybody's doubt that usage of this drug in diabetic patients did pretty well, and there was a reduction in the complications also, which was noted in the same study.
Yeah, thank you, sir. So the next question comes from Mumbai. The question is, Dr. 2017 AHA ACC guidelines suggest 130 to 139 mmHg slash 80 to 89 mmHg as stage 1 hypertension, which is considered as high normal by 2018 ESC and ECH guidelines. In this context, how should we manage our Indian patients?
Sir, would you want to take that question, sir?
Yeah. See, the blood pressure is what we are looking at is depending on the comorbid illness and the age group and other comorbid illness, which makes us to decide what blood pressure we want to maintain. For example, patients with renal disease, we want to bring down the blood pressure to less than 130 or 80. So in such patients, probably we have to treat the blood pressure even between 130 and 140 or even between 85 to 90 diastolic. And in elderly, probably we want to keep the blood pressure a little higher. So based on that, these values also keeps changing. I think that is the message to the question person who has. And Murthy, can you add on something?
Yes, sir. I would totally agree with you, sir. It is an individualized, patient-based individual approach, because each patient is different. Each hypertensive patient with a comorbid condition is going to be different. It depends on whether there is ischemic heart disease, there is a early setting in of the heart failure. Of course, now that we also know that which is called the preserved ejection fraction heart failure. If you are taking all these things into consideration, I think whatever sir says is absolutely correct. It has to be individualized. Tailor-made therapy are what we are going to look at even in future. There is an evidence to say that the lower the blood pressure, considering the low comorbid conditions, the better it is. Keep it at the lowest and try to manage them on that level of the blood pressure. So you can extrapolate the same data. It's worldwide. I've worked in the West, except in the African countries. There is not much of a difference of the blood pressure when compared to the Western world, which can be. So why can't we extrapolate the same data? It is the same. Many of the studies which have been seen are international data, which we conducted internationally. Many of these data which we are already extrapolating and using the same dosages in the Indian patients. So why can't we do that? Many of them are quite effective, and there's not much of a difference between the Indian patients and the Western patients, except the African patients who do not respond to the conventional therapies. They have their own guidelines and the protocols. But other than that, I don't think there is a major difference. The lower the blood pressure and more aggressive treatment, considering the fact that preserved ejection fraction heart failure, it goes unrecognized and untreated. The earlier you catch them, treat them aggressively, preventing the heart failure is going to be the major factor here, sir. I'm sure sir will agree with me on that.
Yeah, I think.
Thank you, sir. So the next question comes from Pune. Dr. Shantanu wants to ask, what is the recent stand of RAS inhibitors in the management of hypertension in the current COVID era?
Sir, you want to take that, sir?
Yeah, current COVID era, there is not much difference in management of hypertension. I don't think there is any difference, except you have to look again the organ dysfunctions. Based on that, you need to adjust the dose. Many of them do end up with AKI, and those things you have to keep in mind. I think, except those comorbid, if there is any other organ involvement, you have to decide the therapy. Otherwise, it is same as in any other patients.
Sir, we are through with all the queries which have been asked, sir. So, anything you would like to say, sir?
I think Dr. Naramurthy has highlighted especially the beta blockers in hypertension, what is its role and different studies. He has quoted MAFI study and other studies. And definitely we have the importance of beta blockers in management of hypertension, which is proven for so long we are using those drugs. The only thing is when we combine with the ACE inhibitors or ARBs, what is its role? So especially with the comorbid illness and other complications which are going to be reduced when we use these drugs. I think he has highlighted the importance of these drugs when we use in optimum dose to keep the blood pressure and control, and organ protection also is there is by these drugs. I think with that, I conclude mine. I want to ask Narayan Murthy to give the important points if he wants to say anything.
Yes, sir. Thank you very much, sir. I would like to highlight only one thing at this point in time. As a cardiologist, from the cardiology perspective, especially as an interventional cardiologist, and also good management of heart failure patients in the long run that we see, I have noticed only one thing. Patients who have been on beta blocker therapy for a long term, they did pretty well, irrespective of the comorbid conditions. Even if there were to be diabetic patients with peripheral vascular diseases where there is no absolute contraindication. One has to be very careful here in use of beta blockers in peripheral vascular disease. It has to be considered as a relative risk rather than an absolute risk. Even in asthmatics, I have not seen that these patients, why should we stop beta blockers when the benefits of beta blockers are more? So we have to be aggressive in using these therapies because there is no absolute contraindication. Even in the COPD asthmatic patients, it is just the relative risk. It's not an absolute risk. So why can't we use this aggressively and give them the benefits? So I find this combination, especially as a cardiologist, both in treating the congestive heart failure and the ischemic heart disease, it's a greatest combination. And 90% of those prescriptions come from the cardiologists who are aggressive like us. So I think this has to be driven. The point has to be driven to the general physicians and to the general practitioners to make sure that they can be used as normally as in the patients with the peripheral vascular disease and those with the COPDs and the bronchial asthma patients. Just have to keep monitoring them. That's all. I think there is no absolute contraindication. Otherwise, this is a wonderful combination, and we have been using it like day in and day out, and we have not found many of the complications as the highlighted in the books. But our personal experience with this combination goes on to tell you how effectively it controls the blood pressure in hypertensive heart disease patients with ischemic heart disease as well as congestive heart failures. We have seen the reports. We have seen the results. They are great. So I think that one has to be aggressive in managing these patients, keeping in mind the long-term benefits for the patients, especially in preventing the sudden cardiac deaths and the cardiac deaths secondary to post-myocardial infarction with the heart failure and other things. Thank you very much.
Any more questions?
No, sir. No. So far, all the questions have been answered, sir. There are no other further questions.
Okay, if there are no questions, I thank Zydus for hosting this meeting. I thank Dr. Narayan Murthy also highlighting the importance of this combination therapy, especially in hypertension, especially in in a setting of hypertension with ischemic heart disease and post-MI, probably they have the best role in controlling the blood pressure.
Thank you, sir. On behalf of Zydus, I would like to thank both of you, Dr. Narayan Murthy as well as Dr. Chandaraya, for giving us this precious time of yours and the learnings that we have got. I'm sure everybody in the audience must have benefited from these learnings. So once again, sir, from the bottom of the heart, I thank both of you for giving us the time. Thank you, sir.
Thank you, Zydus, for your support and beautiful giving me an opportunity to speak about this beautiful combination therapy, um, and giving me this platform. Thank you very much, sir, for being a nice moderator and very kind of you. Thank you.
Thank you, Dr. Murthy.
Thank
To
you,
on
sir.
a Sunday, busy day. Yeah.
Yeah. Yes, sir.
Yes.
Yes, sir. So I just would like to talk to you later regarding the patient.
Okay.
Thank you, sir.
Thank you, sir. Thank you.